Well, good evening, and thank you for joining this EAU Patient Office webinar, in which we will be discussing the impact that surgical treatment for penile, prostate, and bladder cancer will have on intimacy and sexual function for both patients and their partners. My name is Rob Corns. I'm a nurse specialist and a patient advocate for the EAU Patient Advocacy Group. And I'm delighted to be joined by an expert faculty of patient advocates this evening who have kindly agreed to share their own personal experiences, which we hope will provide healthcare professionals with a greater insight and understanding into this subject. So I'm delighted to introduce Mr. Paul Campbell. Paul is a prostate cancer survivor and advocate, as well as being the CEO of Cancer Black Care, a charity based in the UK. Also, Mrs. Jacqueline Daly, who is the co-founder and director of services for East Galway and Midlands Cancer Support. And Jacqueline is also the vice chair of Cancer Patients Europe. And as well as being an advocate for cancer care, she also has experience of being the carer for a husband who was diagnosed with prostate cancer. Also delighted to be joined by Mr. John Osborne, who is a penile cancer advocate, lead patient advocate for UROWebinar Workstream 3, and a patient advocate member of the EAU Guidelines Panel for Penile Cancer. And finally, Miss Susan Richardson. Susan is a mental health counsellor and patient advocate for bladder cancer. Susan underwent a cystectomy and has been a representative for several charities, including Fight Bladder Cancer UK and the Hunger and Thirst Foundation based in the Netherlands. So, although the experience of the faculty relates to different cancers, I'm hoping that there will be a common theme that will emerge, and that as a result of our discussion, healthcare professionals can become a little bit more confident in anticipating the needs of their patients, therefore improving the patient journey. So, I'm going to address a series of questions to all of our faculty about their experience. But before we begin, I'm going to show a couple of slides illustrating some of the expected physical and psychological effects that radical cancer treatment will have on sexual function and intimacy. So, as you can see, there are a wide range of physical and emotional impacts that are associated with any treatment which may alter body image or cause sexual dysfunction. Treatment will inevitably cause a change to an individual's sexual identity, psyche, and quality of life, often necessitating the need for a complete reassessment of what intimacy means. We also need to remember that many patients may be in long-term relationships or have partners who will also need to adjust to the impact of treatment in a supportive and ultimately intimate role, but who may struggle to manage this. In addition, as most cancers are diagnosed in later life, partners may also be at an age where they are experiencing their own physical or emotional changes, which will affect that role. So, my first question to the faculty tonight is, how long did it take you to realise the full impact that treatment would have on your sexual function and intimacy? And how did you initially feel? And I'd like to start with John, if I may.
Thanks, Rob. I think for me, the impact was almost immediate after the first surgery. One of the things that happens with penile cancer is the only way of treating it is through surgery. So you're going to be cut. You lose part of your penis, if not all of it. I was lucky. I was caught fairly early, so I had a radical circumcision. I think the clue is in the radical. Like I say, I got off lightly, but I think it was a real surprise to me. I had no problem handing myself over to the medics to carry out this procedure. Millions of men are circumcised. What difference would that make? What I didn't really understand, and the impact was immediate for the first operation, was that suddenly I had somebody else's penis. It didn't feel like mine, it didn't look like mine, it didn't behave like mine, it didn't do what mine did. And it was a real shock. So you suddenly find yourself with this changed status. And then I had to have 2 further surgeries, one a sentinel node biopsy which led to me having lymphedema, and then a third surgery to take away more cells. And this happened over 4 months. So you're pretty battered by the whole experience, and you realize that your life has changed quite considerably, and issues of intimacy change a lot. I think the most surprising thing for me as well was not just the physical changes, but I had no idea. I really had no idea before the operations of the psychological impact it would have on me. And that was the major thing that was so difficult to deal with.
And what age were you diagnosed? If you...
Oh, blimey. 56.
Okay.
I was 56 when I was diagnosed, yes.
Okay, so thank you. And Paul, from your perspective, I believe you had a radical prostatectomy initially. And how long following that did you sort of realize the potential problems that you would experience?
Hi, so yes, I had a radical prostatectomy, radiotherapy, and hormone treatment. So initially, I didn't hear during the consultation when they were talking about the side effects, etc. That was background noise to me because all I heard was I've been diagnosed with cancer, so it wasn't on my radar. And because I was single, I didn't grasp the impact initially until I entered into a relationship years later. And that's when it really hit me when I attempted intimacy post-surgery and my body didn't respond, I didn't respond. And my partner at the time was telling me that, I wasn't into her, I wasn't sexually attracted to her because of how I was behaving. So on the telephone, I was talking, saying all the right things, but in person, I wasn't doing anything, and that was hard to digest because I thought I was. So emotionally, it was very confusing for me, like facing an invisible loss that I hadn't prepared for. And I wish I had more time to prepare and work myself towards that. So it was a difficult time, difficult to experience, difficult to accept, and difficult to take on. And because I heard the news about the side effects during my consultation, and I hadn't had sex until years later, that's where the confusion was.
And again, I believe you were 49 when you were diagnosed.
I was 49 years old. Yes, that's correct.
Okay, thank you. And Susan, how did you sort of realize, or what were your first feelings?
Thank you, Rob. Well, I'm Susan, and I was diagnosed 7 years ago with stage 3 high-grade advanced bladder cancer. I opted for the radical cystectomy with a full pelvic extenuation. And when I was diagnosed, I had a very different persona to what I am now. I can only say that you go into a bubble, everything goes over your head. You're trying desperately to grasp all the medical jargon that you can, and it's difficult because nobody gives you an actual manual or prepares you for this. At the time, I knew I was very sick and I just wanted to survive. I wanted to live, and that was my real battle. So I focused on this fight and a fight to see the future of my family, and that was my great inspiration. However, after about 3 months, I started getting setbacks. I started learning to live with my new friend, my stoma. And I just wanted to survive, and this is what I wanted to do. So my fight was there, but I had to deal with blockages, sepsis, and adjustments to my diet and how to cope with the stoma. But then afterwards, you're faced with other situations when you want to think of returning to intimacy. The situation that I had, obviously, part of my operation meant that the vagina is closed. So again, before I was diagnosed, if you told me about this, I would have thought, no, you can't do that. This is unreal. But then coming to terms with it and living with it and how you build a future on that is difficult. I sincerely begin to believe that intimacy was totally gone. I was married at the time of my diagnosis and treatment. But I just felt this part of me was lost. My appeal as a woman had gone, and I'd lost confidence in my body, and I was conscious of the fact that there was to be no more penetrative sex. So where do you go from there? I had so many questions, but at that time, my main focus was on healing my body and healing after the radical cystectomy.
And how old were you when you were diagnosed?
I was 63.
63. Okay. And Jacqueline, from the perspective of somebody seeing their partner go through this sort of stage, I mean, how did you feel?
Well, at the beginning, Rob, all I wanted was Mike to be well. That was my main goal, was that he would actually survive the surgery, that he would get well. We were incredibly lucky with the urologist that we had, because he went over and above to try and help us. There was lessons with injections, there was talk through medications. We were sent to see an andrologist. And I know that not everybody is that lucky to get that. But it was the psychological impact that everything had on Mike that became the greatest barrier for us. I was also going through menopause, which I hadn't given a second thought. That in itself brought problems. And I suppose in all of that, I lost me for a very long time. And it was incredibly, incredibly difficult. And we're both very honest when we talk about it. Prostate cancer nearly destroyed our marriage completely and utterly. I mean, everything changed, from having my best friend at my side to having somebody who was sleeping so far over in the bed. I used to ask him if he'd one foot on the floor in case he'd fall out. And where you might smile at that, that was the reality. I mean, there was just nothing. Mike didn't want me anywhere near him, because he just felt so awful in himself that he wasn't going to be able to perform, that it wasn't going to be the way it was before. So yeah, it almost destroyed us.
And I think, well, thank you all for sharing your experience. And I think there's already a couple of sort of common themes that are coming out here. The first is that the impact will be delayed, and especially if you find yourself in a situation like John or Paul, where you need a further treatment afterwards, it can just compound and act as a cumulative problem later on and be much more delayed. But I think the other thing that maybe the audience has picked up on here is that in medical terms, you were all quite young when you were diagnosed, and some people would say in your prime. So, yeah. So bearing in mind the sort of changes in physical function and emotional outlook after treatment, that can completely change the dynamics of a relationship and what intimacy actually means. So my second question really follows on from the first. In how long has it taken you and or your partner to be able to adjust to some form of what you would call intimacy, if this has ever been possible? And again, John, if I could start with you.
It's an interesting question, Rob, because I think it's a very long process, and I'm not actually sure if I have completely adjusted or we have completely adjusted. The initial period was one of just getting through, and I think, as Susan, Paul, and Jacqueline have all said, you go through this sort of medical hiatus of things being done to you. I think the thing that really surprised me was the way in which it questioned who I felt, what I felt of myself as a man. It really fundamentally questioned who I was, and that was a real surprise. That, together with the physical changes, make it very difficult to then embark on a new relation. It's almost like a new relationship. It's a different relationship. You have to overcome the changes that have come to you. My wife was brilliant. She was extremely patient. She was extremely understanding and saying, look, you know, we just take our time. But that is difficult. That is really difficult, because you don't want to. You're wanting to understand what's happened. I think sort of the whole notion of becoming intimate is full of potholes, really. You carry along, then suddenly something will happen that you don't expect or you didn't appreciate would happen, and you realize that things are not the way they used to be. You're not comfortable. I didn't like my wife seeing me naked, which first time ever. Why would I bother? But it was that sense of almost shame about what happened as well. And there's lots of messages of penile cancer in terms of stigma and blame, and people were saying, you know, what did I do to deserve this? You know, where did I put it? All these really insensitive things. So you withdraw. You do withdraw, and actually trying to initiate intimacy or be intimate with somebody is really, really difficult. And that's now 8-9 years. I do have a sex life, which is far more than a lot of men with penile cancer do. So again, I'm very lucky in that sense, but it's not how it was, and it's taken a lot of adjustment. There's a loss of sensitivity, there's a loss of nuance, there's a loss of subtlety, which has made things very different.
Thank you. And again, same question to you, Paul.
I think for me, the adjustments came in stages. It was easy at first because I was single, so there was no pressure to perform, to have sex, etc. And I didn't have to explain anything to anyone. And I guess during that time, again, I was kind of building my relationship with my body, how my body functioned, the weight loss, the scars, etc., etc. But then once in a relationship, it became harder to face intimacy because it felt different. And I guess subconsciously, I avoided it. And I spoke a lot about it, but physically, in the beginning, I couldn't follow through with that. And that was a hard adjustment to make, especially when I wasn't aware of that adjustment. And so getting used to my new self, my new emotions, my body, the changes, that was a hard adjustment. And then having to explain myself consistently to my new partner in terms of how I felt and what I wanted. But often at the end of that, there was no follow through because I didn't have the libido and I wasn't aware that I wasn't following through. So for me, there were difficult conversations, hard conversations, because I was often and consistently saying one thing, but my actions and my reactions was completely opposite. So it was a hard adjustment to make. And then once I understood where the issue was, where the problem lied, I could take steps to make adjustments. And again, that was a continual thing that I had to continue to work on, you know. So I grieved what was lost, and I had to redefine what intimacy and connection meant. And that's not just performance.
Thank you. And Susan, you alluded to it in our last conversation.
Yes, that's an interesting question, but like John and Paul, I don't think I've really adjusted to this, despite it's been several years. I've taken on a new persona. I think that's what I've become. And I really couldn't work it out with my partner. He had his own issues at the time. And I was embarrassed about the stoma in the bag, let alone how do you get around a closed vagina. So I was angry. I was angry for at least 2 to 3 years. And I just couldn't figure out this anger. But I was just happy to come through the cancer. So I thought, well, that's it. I've come through the cancer. I'm doing well. So, you know, I can live without penetrative sex. But it goes further than that. It goes about body image. And I threw myself into keeping busy. But I was only hiding the fact that I had real personal issues to face. And I think it was the dealing with that I suppose, in a way, dealing with other issues had sidetracked and had kept me away from what was actually going on with my body. you know, I used to wear tight clothing. I was wondering, could I wear that again afterwards? You know, coping with two issues, coping with a stoma, and obviously a bag. And at night time, you use a night bag if you want to get any decent sleep. So again, this is something you've got to work out if you're sharing a bed with somebody, and you're plugged into a bag. You know, all of these things. It goes beyond just your body. There are so many other facets of this, and I think it's great this evening because, you know, hearing us talk, people can actually understand what is going on.
Absolutely. Thank you. And Jacqueline, again, you alluded to in our last conversation, but have you ever sort of adjusted or found some sort of normality to intimacy?
I don't know if you'd call it normality. It is very, very different. Like I was 48 when Mike was diagnosed, he was 52. Certainly didn't see this on the radar for us. But we completely lost each other for a long time. Almost like two strangers. We put on the smiles and outwardly we probably looked okay. We tried to keep things as normal as we could because we had a teenage son. Threw ourselves into advocacy, setting up, like everybody else, you were running. You were absolutely on a treadmill and you were running. And it took us a very, very long time to get to the stage where we could actually really sit down and talk and work through the issues were there. Mike also suffered horrendous depression, which almost finished everything for him. So it was all of that that we had to deal with. And I wouldn't wish this on my worst enemy. It was just a horrible time. Yes, we have a good relationship now. We have a very different relationship. And I suppose you learn not to keep looking back and you take it every day that comes as walking forward.
And thank you, Jacqueline. I'm just going to pause there for a minute because I want to share just another slide. So prior to the webinar, I asked the faculty if they could give me some thoughts or feelings of how they felt once everything had sunk in and the full impact had become aware. And if we look back, there are some similarities to what we would expect and the slides that I showed previously. But the thing that really stuck out for me here was the psychological impact, the anger, the desperation, the feeling of being overwhelmed and the need to talk. And so my third question relates to an area of support that I think traditionally healthcare professionals are perhaps not very confident at discussing because they feel they have little experience of it, and that is around psychological support. So my third question to the faculty is, were you and your partner ever offered any psychological support at any stage of your journey? And if so, what type, and did it work? And if you weren't offered it, do you think in retrospect that it would have been helpful? And again, if I can start with John.
No, is a simple question, Rob. Simple answer, sorry. We were not offered anything. I was not offered any sort of counselling or psychological support at the beginning. I think had I been, I'm not sure I was in a position to accept it from the beginning. There were so many other things going on. I think what happens is that about 6 months or so down the line, there may be a possibility to engage with that sort of thing. But at the time, there were so many things going on, it's very difficult to understand. And actually, your communication with your partner is quite difficult, I think, in those periods. I felt very guarded, I felt very uncertain. So, but certainly we were not offered any psychological support then. I suppose subsequently we have, but well, there was a mention of joining a support group, but I think by that time it was 6, 7 years after, and I think we'd worked through stuff that we needed to for us, so that didn't feel absolutely necessary. But no, we didn't. But I think it should be available. I think it should be offered, because I think it would have been extremely helpful if offered at the right time by the right people.
And just on that sort of subject, I know that when you were first diagnosed, you had a lot of support from peer support. So you got a lot of help, and that helped you a great deal. And since then, you have been able to provide peer support to other men, which has helped tremendously. Do you think that peer support is a sort of de facto counselling, or something that can help people come to terms or start to come to terms with what's going on around them?
My instant reaction when things changed was I wanted to understand if other men felt the way I did. If other men who had penile cancer were going through what I was going through. I just couldn't, I needed to speak to other men. And that was really important. There was no option at the centre I was treated at for that to happen. And so I found Your Good Self, and that changed everything for me, really. And that led me into being able to meet with other people, other men who had the experience, and that was so absolutely invaluable. I think peer support is essential. I think there is nothing like being able to be absolutely honest with somebody else who's going through what you've been through. And it's different. We all have different responses. We all have different journeys. But to being able to say, this is happening and I haven't got a clue. Was it like that for you? How can we deal with this? Is invaluable. So I think peer support networks are vital.
I agree. And Paul, in your experience, were you offered counselling, or do you think it would have been helpful?
Yes, but for me, it came too early. I was offered it right after I was diagnosed, in the same room within 3 to 4 minutes. So I had no time to process anything and what had gone on. And it was kind of being forced on me. So I had to really stand my ground and say, you know, this is something I'm probably going to need, but I need to reflect about just being diagnosed with cancer. And that was going to take some time. But that was the only time it was offered throughout the journey. And for me and what happened, I think that that should have been something that was offered throughout the journey and not just once. And I think I should have been signposted to peer support groups. I was told not to go online, and I followed that instruction. And I wish I went online, because I might have found a peer support group like what we have at Cancer Black Care. And then I would have been around individuals that have been on my journey, that know my story, that could have supported me, reduced my isolation, and normalize the conversation that I was going through. So for me, it was quite a lonely journey, because I didn't know where to turn, because I was told not to go online. And I was only told that the information that I was given by the NHS at that time, that's the only information that I should have used. And again, I needed support later on at a later date. I did get it, but I had to go private, and I wasn't offered it again by the NHS. And that's something that I think that should have been offered throughout my journey. My journey lasted 4 years. So I was diagnosed in 2019, and I was offered the psychological support on the day, but I needed it a year later, and a year later, and it never came. And I asked for it a year later, and a year later, and a year later, and it still didn't come.
And I think there's a point there that you've made, is that when is counselling going to work? When is it going to be appropriate? When is somebody going to feel that they need it? And I think this is one of the big problems. I think it's essential, but it's when do you implement it? And so, Susan, having counselling experience yourself, I mean, how were you offered counselling yourself, or how did you feel?
No, I wasn't offered counselling. The words I wanted to hear from anybody really was the words of, at any time in the future, you might need us. That's what I needed. That's what I wanted to hear. But I was very fortunate because I was linked up to fight bladder cancer in the UK. So I could visit their offices because I lived closely. So what happened there was I managed to throw a lot of questions to people directly. But my therapy became actually helping others. So I became a bladder buddy for lots of women who were going through the same operation. And I think this helping others has actually become how I survived myself. It was just a way of turning it around. But I just wanted, I wanted to have known that somebody was there. It was just like a business card or someone to call, without having to research it or do it myself. So really, in answer to the question again, there was no signposting or nothing given to me whatsoever regarding any future help with psychological support.
Thank you. And Jacqueline, how important do you think counselling is, and do you think that it should be extended to partners?
Oh, 100%. And like everybody else, we weren't offered any support. We ended up starting, a support group around our kitchen table. Other men started coming asking Mike questions. We actually didn't realise at the time that we were forming a support group. And I spoke to the partners. Out of that, we now have a community support centre in Galway. But again, there was no support offered when we did eventually look for the help. And at this stage, Mike was very, very depressed in a very, very dark place. And I started looking for someplace. I knew he needed to talk to somebody. It took a very long time to get him there. And when we did, it was absolutely devastating because I had lost my brother and my mother just before Mike was diagnosed. So I got emotional when I got into the room. And we were told that I needed support more than him, which, can you imagine what that did to him? Absolutely devastated when it had taken so long to get in there. So we both came out with appointments, but when we got outside the door, Mike said, you can go, no problem, but I'll never darken that door again, which he didn't. So we then had to find someplace else, and he eventually did get some counselling, which absolutely helped him. But like 6 sessions, I'm sorry, you've just scratched an itch. It is not enough. It needs to be a lot longer than that. Now, I'm incredibly proud of Mike. He has gone back to education. He's now a fully accredited psychotherapist. But it took a very, very long time. And we would always advocate that both people need the counselling. And again, as Paul has said, it needs to be offered over and over again, because none of us come, we're not all the same. One size does not fit all. So it needs to be individualized. And I think that, for health professionals, whoever is listening to this, always be mindful that somebody's mental health, and it's not a competition between men and women, between the patient and the partner. Everybody deserves to get that support there. And it is absolutely crucial for moving on or for forming any sort of a relationship.
And again, I agree. And again, a good point about how many sessions do you need? I mean, the standard, I think, is 6. But how long's a piece of string at the end of the day?
No, well, you're scratching an itch, and I think you actually probably end up doing more damage than good if you're going to get somebody to open up and then say, that's enough, off you go.
Absolutely. Okay, thank you all for that. Now, I think just from my experience of peer support, that I was the chairman of a prostate cancer support group for nearly 20 years, which was open to partners and family members. And to see the interaction, the support, the understanding between couples, both men and women, and the side effects was, in some cases, absolutely transformative. So I'm a big advocate of peer support, and I think that healthcare professionals, if you have a chance, you should really try and get involved in peer support and certainly signpost to it. I have learned a huge amount from support groups over the years. So I recommend that it's something that you should look into. So I think I'm going to create a little summary of what we've sort of discussed so far. I think that despite the faculty having been treated for different cancers, it is clear that there are some common themes which have emerged as a consequence of invasive surgical treatment. And although cystectomy is radically different from surgery for penile cancer or prostate cancer, I don't necessarily think we need to be separating them and putting prostate cancer as having one set of problems, cystectomy having another, and penile cancer having another. I think there are enough common threads that have come out in the discussion that can help healthcare professionals maybe look at this a bit more strategically around support. And so I think maybe the first thing to think about for healthcare professionals is that although information or outcomes and consequences of treatment should, of course, be given at the start of the patient journey, along with a clear understanding of physical changes, this can be quite overwhelming. And it's important for healthcare professionals to realise that the actual full impact of this may happen months down the line. And so it's going to need to be revisited. Somebody is going to need to pick up on these potential problems. I think secondly, as we've heard, what an individual considered normal intimacy before treatment may never be achieved after treatment. And this is going to have quite a profound effect psychologically. And so I think absolutely psychological support, such as counselling, should be offered or promoted at a time when an individual appears receptive to it, but should be offered throughout the patient journey and follow-up. And if necessary, it should be extended to partners, so psychosexual counselling. Now, thirdly, I think the best time to explore these issues will be follow-up appointments after treatment when the impact has occurred. And so follow-up appointments should not just be about PSA levels or scan results. They should be an opportunity to explore the longer-term implications of treatment, especially around sexuality and intimacy, and then initiate support as necessary. Now, in an ideal world, the best setting for this would be in a dedicated follow-up holistic clinic, which is run by a healthcare professional with experience or knowledge of these issues. Now, obviously, in reality, those clinics don't exist, but actually, it only takes a question, it only takes asking a patient or signposting a patient, whether you're a specialist nurse or a clinic nurse, simply starting that conversation or signposting to support can incredibly improve the patient journey. And so I think, fourthly, signposting to peer support at the start of the patient journey can often help patients adjust to the situation outside of the clinical setting, and can be supportive by providing understanding and practical advice for both patients and partners. And I think an example of this, as Susan sort of alluded to, was if you are a newly diagnosed patient who had cystectomy and has spent 2 or 3 weeks frustratingly looking around for suitable underwear that fits around your stoma, somebody in a peer support group may have been in that situation and can offer you direct advice, which saves that looking around and the frustration. And likewise, many charities would also be able to offer supplementary services such as counselling and have healthcare professionals who can give advice in time that you haven't got in clinic. So I think adopting this sort of approach and remembering these particular areas can work for many different types of invasive cancer. I think time-wise, yeah, I think I've got my last question before we perhaps stop for Q&As, and that is to all the panel. In retrospect, what would have been the best advice or signposting you could have been offered by a healthcare professional at the start of your treatment journey? And again, I'll start with John.
I'll be careful here because the risks, I'll just say any would have been useful. But I think the reality is that penile cancer is extremely rare. And the reality for a lot of people outside the large centres, particularly in the UK, so the London centres or Manchester, is that their resources are swallowed up by demands from other cancers, particularly prostate cancer. So they don't see a lot of penile cancer. They don't understand a lot about it. I asked I said I needed to talk, and they just said, well, men don't want to. And that stayed with me because this man definitely was desperate to do it. And I think men do. They just need time. They need some people just to sort of hang on in there with them. And again, I think it's the timing. Again, as we've all said, you're bludgeoned by all this in the first instance. You need time to understand what's happened to you. And then 3 months, 6 months, 9 months, a year is when some of that information is going to be really useful to you, because you just simply can't take it on otherwise. So I think just having some information and some basic information of how to cope with what you're going through, but also just sort of saying, we will be here later, or this is who you contact later. Because that wasn't there for me. It certainly wasn't there for Paul. I'm sure it wasn't there for Susan, because we talked about this before. And I know that with Jacqueline, there was just, you have to create it yourself, because there's very little out there. So, yeah, I think the other thing that's really quite tragic at the moment is charities are struggling. Charities are really struggling with their funding. They're cutting back. They're not able to offer what the service they could 5 years ago. And that is going to have a profound impact on patients. So we've got to find ways ourselves. And I do think that peer support is one of those, particularly with very rare cancers. Then it's online support is probably the only thing you're going to be able to achieve. And I cannot underestimate how important that is. Just having somebody at the end of the line somewhere, whether that's in Australia, Canada, US, or Greece, having somebody there who can talk is just brilliant, vitally important. So know those networks, offer them. You don't have to do anything else, because you're going to be busy. And I'm not blaming any healthcare professional at all. Quite the reverse. I think they're in a really difficult situation.
And as I said, I think in reality, healthcare professionals may have 10 minutes in clinic when they need to just impart everything that you need to know about your journey.
Not enough.
Yeah. So as long as healthcare professionals can signpost to charities, to peer support especially, that will take up a lot of the slack. And I'm just going to ask the rest of the faculty, do you agree with that, Paul?
Yes, signposting, that would have been nice. That would have been amazing. But also for me, representation matters in materials, in services, in conversations and connections. All of the literature that I was given wasn't culturally relevant to me. There were no black faces. There was no one that reflected my age or my culture. And that would have made a difference. Every seminar I went to, I was the only person of color in there. And for me, it mattered because I didn't know if they were talking to me, so I needed to be in a space where I was represented by, whether by healthcare professionals, by other patients, but that was never the case throughout my journey. And I needed signposting to culturally appropriate and relevant services, groups, and charities where I would have normalized the conversation and normalized what was happening to me, but not having access to that, I was isolated. And we need practical advice from our peers and to have access to counselling, which should be ongoing throughout the journey, as we all mentioned earlier.
Absolutely. And Susan, is that something you agree with as well?
Oh, definitely. When we go on this journey, when we're first diagnosed, we have to come to terms with the terminology. HCP, healthcare practitioner. I mean, I didn't know what this person did. Had they seen my job description? Did they know what I did? You know, I struggled with being very poorly and trying to get better, and overcoming cancer, let alone all the jargon that was thrown at me. So I then felt I was a bit lost in the system. I was given checks on my stoma. People were asking me to attend appointments. You know, how was I coping with that? But there was, again, in a quick 5-10 minute appointment, you don't have that opportunity to get close to that person, or to really sit down and be able to explain how you feel or where your problems are. It's a quick, you know, this is your time slot, and that's it. I just wanted maybe some names and numbers, or anybody to hold on to. And I just found that I was really quite lost in the system and quite left to my own devices. So I had to be quite proactive myself. And as I say, you're trying to do all of this, but you're recovering from cancer, you're recovering from your surgery, and you're approaching a completely different life ahead of you.
Thank you. And Jacqueline, from your sort of perspective here, I mean, do you feel there could be anything other than what the rest of the faculty have said that could have been offered to you as a partner?
Yes, of course. And I think we should have been offered appointments with the sex therapist where both of us could actually go there and understand a little bit more about each other. I know there's not enough of them out there, but it's something I think that really needs to be looked at, that we encourage people to actually train in the field. That would have made a huge difference, where we could both sit down and acknowledge the problems that were there. And again, it's the training, we need more nurses doing it. I know that the clinicians, there isn't the time, and we've all acknowledged that. But at the end of the day, we need to be able to live our best lives every day that we get up, and we need to put quality. That's like, you can put years into somebody's life, but we need to put quality into every single day that person gets up. And that comes with peer support.
Absolutely. Well, thank you all very much. I think we've got some time for Q&As. I think there is a question that's come in, but I would just like to sincerely thank you all for sharing those intimate experiences. And I hope that discussion has given the audience some insight into some of the consequences of treatment, and maybe a strategy to try and improve the patient journey. I mean, the best people for healthcare professionals to learn from are patient advocates. And that is the aim of the EAU Patient Office, to facilitate that. So thank you again. And I think there is a question which has come in. And it's around, thank you all for your insights. I'm about to write a paper on sexual well-being of cancer patients. I want to perform interviews to get a broad view of the ideas and concerns of patients. What questions should I ask that you think are often forgotten when talking about this topic by healthcare workers? So I think we've covered a huge amount of what needs to be asked and what needs to be researched in the conversation that we've had. I don't know if anybody wants to offer any other comments.
Well,
For me,
don't forget, sorry, John. I would say, don't forget the partners, talk to them. But I think you need to not just sit there listening to them, you actually need to hear what the patient is saying and ask them. Patients are quite happy to share, as are the partners, if you actually ask them what they need, what was missing. So you don't have to go in with a whole list of questions, just listen to what they're saying.
Exactly, yeah. And I think this is another issue where if you're a cancer patient, you are just going to be totally overwhelmed. As you say, it will just go over your head. If you've got your partner there, they're more likely to maybe pick up on something that will they can support you with or sort of reiterate as time goes on. So I think partners are an exceptionally important factor in the journey, which I kind of think healthcare professionals haven't quite realised.
Can I just raise a point there also is we talk about partners, but we need to include single people, those that might be embarking on new relationships, how you broach the subject of your changed body that's not quite the same as perhaps somebody is expecting. There's a lot around this because things happen in our lives, you know. We go along lives with partners, without partners, you know, lots of different relationships that can happen. So that was just my point.
I think for me, there's the issue was, and it's one of the things I'm trying to work on a lot at the moment, is the whole notion of enabling patients to have constructive conversations with their clinicians and their healthcare professionals. And there is no doubt that your surgeon is going to have to tell you what they have to do to you. They're going to have to explain the plumbing. They're going to have to you know, this is what I am going to do. But actually, one of the things that I think happens for patients is they arrive at those appointments full of questions that they have no idea or no permission to ask. And they go in feeling quite powerless. They're already overwhelmed by the diagnosis. They're overwhelmed by all the different acronyms that are being thrown at them, the different names of things that they've never come across before. And actually, what might be most important to them is, how long am I going to be off work? What is the final financial implication of what's going to happen to me? Because I can't think beyond that into whatever else is going on. Or will I ever have sex again? Will I be the same person again? There are these big questions that are lurking behind, but you can't bring them forward. And I think there's a real need to actually develop some patient questionnaires which we can hand out through clinicians to say, what are the issues that you want to talk about? And there's some really interesting work going on in this, and I think it's about empowering people to ask those questions, because as patients, you don't feel able to do that in the first instance. And it's taken me years to grow, to acquire the courage to do some of those things. Because we all go in the first instance, sort of, oh, yes, doctor, no, doctor. And that's crazy.
I was just going to say that, you know, you need to be multidimensional, because everyone you meet is going to have a different need, and they're going to be looking for you for the answers. And you're going to be meeting people of different personalities. Some are going to be outspoken, some are going to be really quiet. But the quiet ones are going to be the ones that maybe want the more answers. And just because they're quiet, it doesn't mean they don't have anything to say. Maybe they need support to talk in that environment. When I was in that environment, it was very weird for me. Never been in the NHS before, never been to the doctors for this kind of illness before. So it was a unique environment for me. And I needed hand-holding until I had the confidence to speak up. And the majority of us won't have a PhD, so we can't meet you up there. You need to meet us here where we are, using appropriate language that everyone can hear. That's quite simple and easier to digest, and just be consistent as well. And we want facts as well. You know, tell us what we're going to go through, how it's going to be. You know, signpost us to culturally appropriate literature, whatever it takes to make sure that we leave there with the answers that we need, and we don't go back worrying. And that's what happens a lot. We leave those environments and we're still no better off, because we don't know, you know, we didn't understand the language, we didn't understand the contexts. So it's making sure that you're multidimensional so you can meet us where we are, and we can leave that room, that surgery, understanding everything and all the pros and the cons of what's going to happen to us.
And I think it's been very interesting that, as one of the things that we set out, we would hope we would find, is that there are common themes here. And, you know, you've had treatments for different cancers. So surely this makes it potentially easier for healthcare professionals not to be compartmentalizing one cancer with one set of potential problems, but if they're dealing with anybody who's been through an invasive surgical treatment, there is this common thread. And I know, as I said, you've all had different treatments, but do you sort of agree that having listened to each other, that thread there is a common thread there?
Absolutely.
Yeah, I think we, because we've all sort of found each other, there's an element of common healing throughout, because a lot of our mental healing can be done with talking to people that understand us, and that's where we find the colleagues and where we come across people, the people on the panel today, because that in a way is our therapy.
So I think that the strategy that we've sort of suggested would probably work for the majority of people who find themselves in these sort of similar situations. So firstly, that the full impact is only going to be realised months down the line. So it needs to be picked up at a follow-up. That is extremely important. Two, the psychological impact for both partners and patients cannot be underestimated, can be absolutely damaging and needs to be picked up. And three, that if you haven't got time to maybe spend 20 minutes talking about the longer term effects, or patients are not in the right frame of mind to do that, then simply by signposting, charities, peer support will take a huge amount of pressure off of that patient and improve their journey. So I think that's been a very interesting discussion. And I hope the audience has gained some insight and thinks that has been useful. And I think we're coming up to time, so I'd just like to say again, thank you to the faculty for sharing such intimacy. It's much appreciated, and it's the future to change the way healthcare professionals practice.
Thank you.
Thank you.
Thanks, Rob. Thank you, guys.
Thank you.
Thank you, everyone.
Thank you, everyone.
Thank you.